Hello, good evening. Yeah, sure. We'll talk about guarding rigidity. So, welcome to session 16, and we'll talk about extrahepatic biliary apparatus. As such, primarily gallbladder, right? But whatever is outside the liver, and if it is associated with bile, that's what we'll be talking about today, right? So, when we say that book for physiology, Guyton is very good. Actually, Guyton is like a storybook. So, though you have to make notes of yours, but in Guyton everything is described in such a lucid way that you will feel that instead of say studying anything, you are just reading a storybook. So very fine book, but you have to make notes, right? Yeah, I'll update you about that. Okay, so the components, right? Components of extrahepatic biliary apparatus, right? From now onwards, we'll start writing it in short. So one, what we'll be covering? Right and left hepatic ducts, right? That is from the liver. Then they lead to formation of common hepatic duct. Then there would be cystic duct, right? Because that cystic duct which will be going into the gallbladder, and both will be going into what's called as the common bile duct. That's where the pancreatic duct would meet, right? And they will open into D2, correct? So all these are extrahepatic biliary apparatus. So right hepatic duct, left hepatic duct, common hepatic duct, cystic duct, common bile duct, and the gall bladder. This is what we'll be talking about. Okay, now let's see few of the figures. They are completely self-explanatory, right? So that's what we saw, right and left hepatic ducts, common hepatic duct, cystic duct, gallbladder, bile duct or the common bile duct, and pancreatic duct, and that is hepatopancreatic ampulla, and that is the wall of duodenum, that is D2, right? Over here, this is also called as ampulla of Vater. So as such, we know it very well that the function of gallbladder is that whenever those fatty foods they are consumed, they lead to trigger of cholecystokinin, right? That cholecystokinin, pancreozymin, that's right. And this is what causes gallbladder to shrink, and thus the bile is put it into D2, right? Just for the theory purpose, the size of the gallbladder is about 7 to 10 centimeters in length, right? 7 to 10 centimeters in length, about 3 to 4 inches. And its capacity, right? Its capacity to store, it varies, but roughly it is about 30 to 50 ml. And as we know it very well that it is not only the storage, but function of gallbladder is to concentrate, right? To concentrate the bile. That's also one of the function. This concentration, it can be from 10x to 50x. So that's the primary and the basic thing of gallbladder. Now see, this is about some interesting thing. These are what is called as the accessory hepatic ducts, right? Accessory hepatic duct. Say if the hepatic ducts, they are common bile duct supply transverse colon. How come? Transverse colon? No, no. CBD, it opens into the second part of duodenum. Right? Common bile duct, it opens into the second part of duodenum. And that's from where it will lead to the process of saponification, that is breaking of saponification, that is breakdown of large fat globules into smaller micelles, and these are then easily digestible, right? They are easily digested on the course of, say, beyond D2, right? So that's the function. Okay, so now these are like accessory hepatic ducts. So by if the hepatic ducts are Sharif, so that's okay. They will be opening like this, but they may open into, say, directly into the gallbladder, or they may open into cystic duct, or they may open like this, right? Any one of them, it may open into this common hepatic duct, or it can open into common bile duct. Well, if they open in any of these areas, right, that is what we are talking about, the hepatic ducts, right? We are talking about hepatic ducts. So we'll call them accessory hepatic duct. Accessory. Now the importance of it is that we'll see that whenever there are cholelithiasis, that is the stones into the gallbladder, or in cases when there is infection, right? So if it is short interval, that is acute cholecystitis, and if it is a prolonged one, then it is called as the chronic cholecystitis. And classically, chronic cholecystitis may lead to the gallbladder, which is absolutely like, it is called as the porcelain gallbladder, right? So in such cases, because of that calcification, you have to remove the entire bladder. That is what is called as the cholecystectomy. We'll see it more. But when you do it, right, when you really cut it, when you cut it and you remove the gallbladder, because of the presence of all these accessory hepatic ducts, you will find that still the bile is continuously oozing, right? Oozing of the bile continues. So that's where you need to take care of it. Biliary apparatus. Apparatus means devices, and those devices or those say part of the organs which are associated with bile, right? So you know it very well that bile, it is produced by liver. So liver in itself is a complete entity, but anything outside the liver, that is what is called as the extrahepatic, right? And biliary apparatus, that is something which is associated with bile. Apparatus means all those devices, so we'll call them all them as devices. So this is hepatic, and rest are all extrahepatic. Okay. Now this figure is really very important. Watch for first part. We understand this common hepatic duct. Yes, this is good, right? Common hepatic duct. And we also know the cystic duct. So that is common hepatic. This one is cystic. And when we draw one more line above, right, that is where the liver is. So the triangle which is formed, this triangle which is formed, that's called as the Callot's triangle. That is called as the Callot's triangle, right? So this is first point. Rest is, say, liver. Regarding the Hartmann's pouch, it's simple. The gallbladder, in the neck there is a protrusion sort of area, right? Then this is a protrusion. There is a sac-like structure. right? Where this is the area where the stone can be lodged very easily because it's like a pouch, right? It's like a pouch. So that's why it is called as the Hartmann's pouch. So that's where the stone can be lodged. As such, it is slight expanded area, but that is the area where the stone can be lodged. And once the stone is lodged, it will keep on increasing and gradually it will obliterate the entire neck. And that's where the obstruction starts. Correct? So regarding the parts, things are like one, that is the body of gallbladder, second is fundus of gallbladder, right? And then we have got, say, rest is all the neck and the cystic duct. So this is the bile duct, that is the first part of duodenum, head of pancreas, all is fine. Okay, regarding the blood supply, right? If you see the blood supply, that's the, or don't worry, blood supply we are taking in another figure, right? In full detail. So this is like, say, Callot's triangle, right? In Callot's triangle, there would be cystic artery. So the artery is this, right? Cystic artery. This cystic artery, you remember, which is coming from right hepatic artery. Right hepatic, which is a branch of, say, common hepatic. Common hepatic, which is coming from, say, celiac trunk. Celiac trunk, which is from aorta. And that tells that, okay, it is from celiac trunk. Celiac trunk. So that means we are dealing with foregut, right? Foregut. So that is, so in case of, say, Callot's triangle contents, one is the cystic artery. And then another thing is cystic lymph node, right? So just remember this cystic lymph node, which is shown over here, cystic lymph node. And plus there would be autonomic nervous system fibers, right, which will be supplying the gallbladder. Okay. So we were talking about gallbladder parts. Let's do it in the brain mapping format. The fundus, body, and the neck. So in the figure also, right, we have seen this fundus. In between, that's the body and that's the neck. Now see, regarding the fundus, fundus is its importance. I'm just writing important points. That is the point that when we draw that, okay, this is liver. And then we draw gracefully that, oh yeah, this is gallbladder. Actually, this is fundus of gallbladder. Right? So that's where it is seen that which is projecting beyond liver. Right? Projecting beyond liver. So this is one point to remember. The body, this body is in the fossa, So when we'll be studying liver, at that point we'll see that in liver there is actually a depression in which this body is sitting, and it is the fundus which is extending beyond the liver, right? So this is easy. Regarding the neck, yeah, it is bit specific because it is the narrow end, and that's why all those stones, they will be torturing this area, right? So this is the narrow upper end. On top of it, it has got that Hartmann's pouch. So this pouch, right? It is like that. It is like this. So because it is an extra area, that's where the stones, they can get lodged, right? And then it will cause all the troubles. Now, as such, we'll be watching that these gallstones, technically called as the cholelithiasis. Lithia, lith means stone. Gall means it is associated with bile, right? Asis, that is the process. So formation of gallstones, that is what is called as the cholelithiasis. Now see, today we'll be watching even the ultrasound images just for one particular reason, and that reason is that whenever you see a stone, right, let's say you take a torch and then this is the beam of light, that's the torch, that's the source, right, this is the beam, and if there is any object over here, so behind the object, right, behind the object there won't be any light, so this is what is called as the shadow. Am I right? So if there is a huge screen over here, so we'll be watching a big shadow over here. But this is the principle which you have to remember, because when we'll see, we'll understand that over here we are talking about light, and when we'll be discussing about ultrasound, there is nothing but it is the sound, that is the ultrasonic sound, the sound which is beyond the reach of our audible range, which is 20 hertz to 20 kilohertz, correct? That is our audible range. Means ideally, say dogs, they have got the range up to say 35 kilohertz, so that's why any of the sound produced at like say 27, 28, 29, 30, humans they won't be able to understand, but those dogs they will be able to understand. That's the reason there was invention of what's called as the silent whistle, right? Silent whistle is like if you blow that whistle, right, it will generate the sound at 27 kilohertz, 27,000 cycles per second. It is impossible for any of the human to hear that, but those dogs will hear, and then they will reach to that spot, right? And in case if you really want to see that how effective this thing can be, once again a movie is coming up, right? And that is Doberman Gang. Oh yes, Doberman Gang. Doberman, you know, they are the one of the most intelligent breed of dogs, right? So those few intelligent people, they feel like that let's train these Dobermans because they are ferocious, and those dogs they were trained with these specific whistles, and then with the binoculars they were watching those dogs. They were told to attack the bank. They enter into the bank, and in their neck the message was written, and those big bags were written that just put all the money into these bags, otherwise they will attack, right? Someone tried to play smart, immediately they blew that whistle which was like attack him, right? So every dog was trained accordingly. So and they were controlling all the dogs with those whistles, but the end is amazing, right? So in case if you get the chance, just watch this, right, that how effective those ultrasonic waves they can be. Okay, anyway, over here we'll be dealing with those ultrasonic waves which are much higher. So when these waves they go and the stone is over here, yes, in the background we'll be getting the shadow, and that is what is called as the acoustic shadow, right? We'll see that. We'll see that. Okay. So normally these gallstones are radiolucent, right? They are radiolucent. Radiolucent means on plain X-ray we don't see it, right? You can't see it on plain X-ray. Subject to that if there is involvement of calcium salts. If the calcium salts are there, so then they can be seen. That is the calcification. Otherwise, they are not seen. We'll talk more about the types of stone. At least two types of stones you must know, that is those cholesterol and biliary. But this is just a basic of it. Okay. Some structures, as such you know these structures, and that is our favorite porta hepatis, right, which is like a music, hepatic artery, portal vein, bile duct, right? So porta hepatis, that is that area which is comprising of say hepatic artery, here it is, right? So hepatic artery, portal vein, and bile duct. This is bit important. Turned up. Turned up means because in order to see that porta hepatis, so actually the all these structures, these three structures, they are together, and that is what is called as porta hepatis. है ना? But to see it, right, you have to actually lift so that you can see rest of the structures. In our dissection, what we try to do, we in order to see this, we sacrifice some portion of the liver so that it can be seen. So in any case, these are the three structures which are together. Okay. Then yes, ligamentum teres, right? We have talked about it. Ligamentum teres, which is like remnant of those umbilical veins. True, umbilical vein. And yeah, this is ligamentum venosum. Ligamentum venosum, which was like remnant of the ductus venosus, right? Ductus venosus. And during our fetal circulation, we talked about it that this ductus venosus, he is everything because he is someone who is bypassing the hepatic circulation. Otherwise liver is P2, right? He'll eat up entire oxygen, right? How sarcastic. So he'll eat up entire oxygen, but it is this ductus venosus, he sneaks in the blood, bypasses the liver and puts it into vena cava, and then it goes for the entire fetus. So very important. But because this ductus venosus and this umbilical veins, once after birth, their functions are over. So these are like remnants of ductus venosus and umbilical vein in the form of ligamentum venosum and ligamentum teres respectively, right? We talked about it, so just a sort of revision. Okay, some name, wall of Easter, right? This is the wall of Easter. Actually it is not a wall. Yes, this is common hepatic duct, and this one is cystic duct, right? That one is cystic duct. So here it is like this is 1, that is 2, and over here it was liver, and this is what was forming that Callot's triangle, correct? Callot's triangle. Okay, in Callot's triangle, this is cystic lymph node. Plus what was there? There was cystic artery, right? Cystic artery. Cystic artery was the branch of right hepatic artery. Right hepatic branch of common hepatic artery. And to celiac trunk and to aorta. Okay. So these are the cystic duct with spiral wall of Hieser. Now these valves, right, they are nothing but they are the mucous membrane which is thrown into folds. So actually it is not valve, but because the mucous membranes, they are into folds, so it slows down the entire speed, right? It slows down. So it is acting like a valve, or acting like a, we can say acting like a control mechanism. So these are the mucous membrane folds, right? These are mucous membrane folds. So not a true wall, but that's how it controls. Okay. So regarding the functions of gallbladder, these, the storage and the concentration, increased concentration of bile, that is beyond doubt, you know it properly. We'll also understand, conjugated bilirubin, unconjugated, direct bilirubin, and indirect bilirubin. Right? Because when we see any of the LFT, liver function test, we watch, and the lipid profile, right? You'll find that these are the values which are written. So what exactly do they convey? Right? Sometimes we see that okay, there is increased CRP, C reactive protein is increased. There is increased alkaline phosphatase, right? That's what we see. Or we see that there is increased indirect bilirubin, or there is increased direct bilirubin. Now, what exactly all these things they are trying to convey? Say, if we understand it by this, no, because the question is important. That's why I'm answering it. See, you Minu, actually you will laugh on yourself, right? I'm not telling bad about, but this is really very interesting. So because one answer, single answer is that all these remnants they again develop at time of next child delivery or new vessels. These are which are developing into the fetus, right? Not into the mother. You got the idea, right? And then you will say, "Arey, ha, yes, right? This is placenta, right? Placenta will be in mother, and then this is umbilical cord, correct? And then in this umbilical cord, there would be umbilical vessels, that is veins and arteries, umbilical vein and artery. So that entire game is happening into the fetus. Once the baby is born, right, the baby will be born with the ligamentum teres and ligamentum venosum. Everything will be with the baby only, right? So in the next delivery, there would be new baby. So obviously he'll be developing new ligamentum teres and I mean new umbilical veins and new ductus venosus. You got the thing, right? Mother would remain same, but here, this is the area where things would happen, right? I think you got the answer. It happens sometimes, so no worries. It is good that you asked me because say what if this error is conducted in exam, so it is completely fine. Say all these things they are happening at the level of fetus, correct? Because mother for mother this is just the placenta, right? And that is also removed. So done. Okay. So concentration of bile. Another is absorption. Absorption of all those loose salts. Right? And there are salts like bile salts, and the cholesterol. You need to know just this game, right? That these bile salts and cholesterol, their balance is so important. If there is some problem, if the cholesterols are increased and bile salts decrease, then that acts for the nidus. Nidus means seed. So if the cholesterols they increase, right? If they increase, so they will act like a nidus. Nidus means the seed around which the gallstone will keep on forming, right? So gallstone will keep on forming. So that's how it goes. No, that's fine. That's completely fine. Never be confused. So it is that's what I always encourage that in case if I miss answering any of your question, right, Bindas, you just send a mail. So it is completely fine. Means I'm happy that at least that confusion is removed. Okay. So right this so when we'll be talking about those gallstones, at that point we'll see that how it happens that if the cholesterol they are increased and if these bile salts they decrease, so that means this cholesterol will not be dissolved properly and that will be leading to that's nidus or the seed, and that will lead to formation of those gallstones, right? So this is the very basic of this entire system. And fourth thing is that because this gallbladder, right, this is it can contract, it can dilate. So the entire biliary system, right, the entire biliary system, its pressure is controlled. So this gallbladder will control the pressure, right? Pressure is controlled by dilatation or contraction of gallbladder. So these are the major functions. Okay, here it is. This is CBD, common bile duct. Now for this CBD, it is divided into several parts, right? Very easy and very normal. This is like common hepatic duct, right? This one is our cystic duct. We are dealing with this portion. We are dealing with this portion because actually it will go into the second part of duodenum, right? So we are just dealing with that part, and it is divided into four parts. That's D1, duodenum. So this portion is 1. Then there would be second portion which is just behind the duodenum. Then there is third portion. And then there would be fourth portion which would be going into the D2. So we'll just write 4. Let's name them 1, 2, 3 and 4. This is above duodenum. So simple. Supraduodenum. Then there is one which is just behind the duodenum. So we'll call it retroduodenum. Now I am writing for duodenum, just writing B. Then this is below. So we'll write infraduodenum. And then this fourth part will be entering into the duodenum. So we'll write intra in capital so that we don't confuse between infra and intra. Intraduodenum. Got it? So these are the four parts. Right? Normally this CBD, just for theory purpose, the length is about 3 inches, 8 centimeters, right? 2.5 centimeter is 1 inch. And its diameter, right? Its lumen, that is very thin, just 6 mm. Okay. All right. Watch for this part. This part should be completely clear. All the structures, yes, the porta hepatis, that is fine. Right lobe of liver, no extra marks for that, right? This is gallbladder. Yes, this is the extra projection, so that would be fundus. And this depression in which the whole thing is sitting, that is the body, right? This is that disciplined quadrate lobe. And this ligamentum teres, now you know it so well, so I need not say about it. This is the fissure for ligamentum venosum, that is very good. And this is the caudate lobe. Caudate means this is bit irregular shaped, right? It is irregular shaped, so that is caudate lobe. Quadrate is four-sided, disciplined, good. All right. Let's see the CBD parts, right? The first one was supraduodenal. So in supraduodenal, in its anterior part, what would you see? Simply liver, right? Nothing else can be there, because as such, the entire this extrahepatic biliary, they are just behind the liver, right? Till the fundus of the gallbladder comes. So this is anteriorly, it is liver. How about posteriorly? Behind, right? And you already know that, right? It is this portal vein, right? Because portal vein is big, that big portal vein in which all those hepatic veins, they were draining, right? So portal vein, and I would mark a star because that's what we need to remember. Epiploic foramen. Epiploic foramen. This is easy to forget, so we'll remember that part, right? And on the left side, worth remembering, so that's why one more star, it is the hepatic artery. So this gives us a very clear picture that common bile duct On its left side there is hepatic artery, and on its back side behind it is the portal vein, right? So portal vein on the back side, right? Then we have got, say, common bile duct, and this one is hepatic artery, right? So this is anterior, this is left, this is right, and we know this. Now we know all this, right? So this is portal vein, this one is CBD, and this is, say, hepatic artery. Okay. The second one is retroduodenal behind. So again, who will be anterior to it? No marks for that, because this is retroduodenal. So this structure is behind duodenum. So anteriorly it has to be duodenum. Correct. How about the posterior? Who will be behind it? Say above it is portal vein, right? This portal vein. And as it goes down, there comes the IVC, infra vena cava. And on the left side, again, this is to be remembered, gastroduodenal artery. Gastroduodenal artery. Finally, the infraduodenal. Infraduodenal to is entirely into the groove in pancreas, because say that's how things are, right? That's how things are. This is all pancreas. So the moment it comes over here, so this part which is just right, so this is duodenum, right? So this infraduodenum means actual infraduodenum is into the groove, is groove in pancreas. So there is nothing more, right? No more further relation, because it is purely into the substance of, say, pancreas, and then it enters, right? So this infra and that intra duodenum, it is into that ampulla of Vater. Ampulla of Vater. So not a very complicated thing, just 2 or 3 important things which are to be remembered, because then they will be playing like a trump card. So this is 1, that's 2, that's 3, right? Okay. Yes. Figure is very good. Just some important things about those sphincters. What we are watching is that this is the bile duct which is coming from the top, and from here it is the pancreatic duct, and they are opening. So all these rings, they are actually showing that yes, we are dealing with those sphincters. So this sphincter choledocus, simply speaking, this is the sphincter which is for this bile duct, right? And this is always present, always present. So it means there must be something else which is not always present, and that is sphincter pancreaticus. This one, this one we are dealing with. This is what we are talking about, right? So not always present. Okay, this is done. Now this is sphincter ampullae, the main sphincter. Definitely be present, right? Definitely be present, because it is main. So it is present, right? So this much is should be known to you, that it is the sphincter choledocus and sphincter ampulla which are present. Pancreaticus present or absent, right? So not always present. And yes, all these are smooth muscles, correct? These are smooth muscles, because after eating butter we don't really tell to our digestive system, okay, yes, butter is coming, so open up, right? We don't say that. All right, that was for what I was waiting for. This is say blood supply to gallbladder, right? And it is like you know it. So it is by cystic artery. So we go ulta, right? This cystic artery is divided into two branches, anterior posterior. So this is one cystic artery. Cystic artery, the branch of this. It's not marked. Okay, no problem. This is. Oh, see, this is incorrect. Right branch of hepatic artery. In fact, this is the right branch of hepatic artery. Correct? They have marked it. Say these ducts they have marked. Actually, it should be like this. Say, just a minute. Right? It has to be. It has to be like this. Now it is okay. Right? That's the right branch of hepatic artery. Cystic is branch of that. So that is 2, right? They lead to formation of this proper hepatic artery. Then this is common hepatic artery, and that common hepatic artery will go to celiac. I mean it will come from the celiac. Okay. Meantime, over here, that's the right gastroepiploic, right gastroepiploic artery, which will be meeting right gastroepiploic. Now these are all long names, so that means this will be at a greater curvature of stomach, right? This is superior pancreaticoduodenal artery. All right, this is superior pancreaticoduodenal. So that means there must be inferior pancreaticoduodenal artery. So this inferior pancreaticoduodenal artery must be a branch of, well, let's bluff. This is foregut. That means now as it will go down, we'll be dealing with the midgut. So is it superior mesenteric artery? Right? Bang on. You are absolutely right. This is right. It is a branch of superior mesenteric artery. Because in the entire digestive system, just there are 3: celiac, superior mesenteric artery, and the inferior mesenteric artery. And yesterday you answered it very correctly. That is for the venous system, right? There is superior mesenteric vein, inferior mesenteric vein. Yes, they are for midgut and the hindgut, but for the foregut, as you said it so perfectly, and it is the splenic vein, right? That's the trump card. That is only which we need to remember. Rest is all easy. Okay. So for the venous drainage, superior surface, all those veins, right, they collect and they go to hepatic veins. And the remaining ones, right, from the remaining area, from the rest of the areas, they will go to cystic veins. And these cystic veins will be going into the nearest, that is the portal vein. Right. So that's how the venous drainage is. Yes, hello. Now for the lymphatic drainage, that cystic node which we saw into that Callot's triangle, yes, he plays a major role, right? He'll play a major role because whenever there is cystitis, cholecystitis, this cystic node that would be enlarged, right? That would be enlarged. So gallbladder, cystic duct, right? They are absolutely near. Hepatic ducts, all of them, they are near that Callot's triangle, right? They drain into this cystic lymph node, correct, or cystic node. or you can just say cystic node. But remember, it is into that Callot's triangle, right? Callot. Portal cable anastomosis we have talked in extensive detail, right? So right now we will not be touching about it because it will be deviating completely, because esophageal varices, those hemorrhoids into the bare area of liver, all those things have been discussed. Okay, so this is cystic lymph node. So that's the first part, right? Also one thing, that for the bile duct, the upper part, right, that is also into this cystic lymph node. And for the lower part, lower bile duct, it is into that pancreaticosplenic nodes, right? So we'll just write pancreaticosplenic nodes. So over here, we'll remember this part and this part. And yes, the Callot's triangle, right? So these are the important keywords. Regarding the nerve supply, so it is the celiac plexus, right? Then the right vagus. See, all of them together, plus the right phrenic, all these nerves, actually, they will lead to formation of what's called as the hepatic plexus. Say in GIT, you'll find lots of such plexuses lead to cystic plexus, because it gives the plan A, plan B, plan C. So in case if there is some damage, at least from one or other nerve, you are getting the proper supply. And this is what really supplies the gallbladder, right? And then it supplies gallbladder, it supplies common bile duct, but again this common bile duct, only the upper part. What about the lower part of CBD? It has got a specific plexus. That is, we have seen that these are the plexuses over some vessels. So over here, this is the plexus which is formed over superior pancreatico-duodenal artery. That is what would be supplied to this lower common bile duct, right? So this is, yeah. Sympathetic, very standard, and the parasympathetic, right? And we know this part. Sympathetic for stress, T7, because this is higher, to T9. This is vasomotor, correct? Vasomotor. And it is motor to sphincters. So it will say, okay, all sphincters close, right? So sphincters, they are closed, because no need. Right now, it is a stressful situation. So there is no need for them to do any of the digestion. Parasympathetic, it is eat and rest, right? Eat and rest. So it is just the reverse of entire thing. So over here, it would be motor to gallbladder muscles, right? Gallbladder muscles. Okay, come on, gallbladder, you contract, right? So gallbladder would contract. When gallbladder is contracting, so all those sphincters which we saw, this would be inhibitory to those sphincters, right? When inhibitory means those muscles would relax. When they will relax, that means those sphincters would open. So in simple words, sphincters, they open. Once they open, so rest of the process is known to you, right? See, whenever there is any pain, anything wrong into the gallbladder, so it will be distended, it will lead to that pain, right? So that is a local pain which is into the right upper quadrant over here. That would be the location where there will be pain. But then there would be some referred pain. So we are now dealing with the referred pain, right? We are dealing with the referred pain. So one, it will be on the right shoulder, and second, inferior angle of scapula. So this is one and this is two. Collectively they are called as the Boaz sign. Boaz sign. Boaz sign. Right? So pain in the right shoulder and the pain in the inferior angle of right scapula. Classically, say whenever there is any problem in the gallbladder, usually you will see that the pain occurs after the food, because it is the food which triggers cholecystokinin pancreazymin, and gallbladder is trying to contract because there is obstruction, so it is generating pressure and that leads to pain, right? Okay. Moving further, say we talk about biliary obstruction. Now from this point onwards, almost the anatomy is complete and we will be going some of the physiology, some of the medicine, some of the pathology, right? So it would be a sort of mixed thing, including the radiodiagnosis. So biliary obstruction, so when liver is producing that bile, and that bile will be going into the duodenum, right? As such, duodenum via all those paths. If it is not going into the duodenum, so what would happen? Those salts, that is bilirubin, another one is biliverdin, right? So they are now into the liver. It is the bilirubin which imparts, it gives yellow color. It gives this yellow color, right? Because there is obstruction. And that's what is called as the yellowish hue, that is the jaundice or the jaundice. Jaundice, right? And this would be excreted in urine. Excreted in urine. And that's why urine will be yellow colored. Right? How about duodenum? Well, these salts, they are now not going into the duodenum. So this means that as it will proceed further, the stool, it would be light colored. It would be light colored. Collectively, this thing and this thing. This tells, it gives the hint that, okay, we are dealing with obstructive jaundice, right? Obstructive jaundice. Now this bilirubin, can there be non-obstructive jaundice? Yes, it can be. Because see, right now it is, liver is making normal, say, bilirubin, but it is not going into the duodenum. What if large amount of cells, they start breaking and then they dump so much of bilirubin that liver is unable to process, right? Say for example in hemolysis, say for example sickle cell anemia, right? When bichara RBCs, they are immature and they are breaking at a very high rate. So that is where it comes like non-obstructive jaundice, right? Now in this, whenever there is obstructive jaundice, see, this differential diagnosis is very important. That is when you ask the patient that, and that is what is called as the history. You ask, is there any pain, right? And we'll be dealing with this pain, that what exactly is the Murphy's sign, right? Just in 2 minutes we'll talk about it. So we'll talk about that, is he having pain, and if it is in that right upper quadrant, and you tell the patient that, okay, as I am palpating, right, take a deep breathe. When the patient takes deep breathe, it is the diaphragm which hits the gallbladder, Now this gallbladder is actually inflamed, right? So it will generate, it will give pain. So patient will hold his breath, right? He'll not deep breathe. So the typical thing will be, and he'll hold his breath. So that is when it is like, okay, we are dealing with biliary stones and this entire gallbladder must be studied with it. So what will you do? You will straight away go for USG abdomen. You will not go for X-ray, because chances are that if these stones are radiolucent, you won't be able to see them. Unless there is calcium component, if they are calcified, if it is a chronic cholecystitis, right, in which the entire gallbladder is like porcelain, right, if it is fully calcified, so it is like porcelain, so then you can see. But if the history is short, don't go for say X-ray, straight away go for ultrasound, right, and I'll show you that how the USG picture would really look like. Now in this, if the patient, right, if he tells that there is heavy weight loss, don't ignore this thing. If there is weight loss, so then the weight loss, they are associated with carcinoma. So straight away put a query. Can it be CA, carcinoma of head of pancreas? Because if it is carcinoma of head of pancreas, right, so that will also lead to this obstruction, right, because of this carcinoma of head of pancreas, that common bile duct which is passing through the pancreas will throttle it. Once it will throttle, none of the bile is going, that's it, it is obstruction. So in such case, you will go for CT abdomen. Why CT abdomen? Right, it is because we don't want just to see the carcinoma of head of pancreas. Because it is a fast spreading carcinoma, we would definitely like to see the secondaries, metastasis. Because that will help us to plan the entire treatment. So this is the reason the history is so important. Okay. Now over here, that's like gallstones, they are blocking the bile duct, right? It could be anywhere. It could be anywhere. Achha. Now, as I said, that we'll talk a bit about the types of gallstones. So, in types, one is the cholesterol gallstones. Almost 90% of the cases, it is cholesterol gallstone. So they are yellow, and important point is that they are radiolucent. That means plain X-ray, right? Plain X-ray is of no use. You need to go for USG ultrasound. As I said, we'll just have a look at it, that how it really looks like. But why it occurs? The commonest is that every examiner would expect that it is common in fertile female in 40s, 40, and she is fat. And there is a very good reason associated for all of them, right? Now, why, to understand this, watch for, I'm changing the color. Cholesterol, right? Why these stones develop? Then there are cholesterol, right? In the bile, cholesterol, and then there are bile salts. What these bile salts do? These bile salts, they dissolve the cholesterol. So if there is increased cholesterol or decreased bile salts, that would lead to formation of gallstones. Easy, simple. So now let's see how it really happens that there is increased cholesterol, and how it happens that those bile salts, they are decreased. See, it is in this phase of female life when there is increased estrogen. True? There is increased estrogen. When there is increased estrogen, there is increase in the activity, right? Activity of a very specific enzyme. This is what is called as the hydroxymethylglutaril, right? HMG in other hydroxymethylglutaril coenzyme reductase. Reductase. Now what it is doing? This is what is leading to increased cholesterol synthesis. So when there is increased activity of this HMG-CoA, so that means there would be increased cholesterol production, right? Increased cholesterol synthesis. And where it is happening? In liver. So more cholesterol is produced. Bile salts, they are into the same quantity. This means that now excess cholesterol may lead to formation of those gallstones, right? So this is one. Second, obesity. Obesity itself means high cholesterol, right? High cholesterol. So that is. And the third one, this is interesting. There would be increased progesterone also, correct? Because in the menstrual cycle, it is the estrogen, progesterone, right? They keep on that cyclically go up and down. So over here, this increased progesterone will actually lead to decrease bile acid secretion. So bile salts, they are decreased. Bile salts, they are decreased. So all of them together, they are going towards formation of gallstones, right? So that's why this is like 4F, which is like very high yield thing, and you must remember, right? So this is first type, that is the cholesterol. There are even other types also, but at least two types you must know. This is one is cholesterol gallstones, and now the second one, because this second one is completely different. This is bilirubin gallstones. Bilirubin gallstones. This is classically because of extravascular hemolysis. Extravascular hemolysis. Now it could be as we were talking about that, let's say sickle cell anemia, right? Those RBCs, they rupture at a very high rate. Hereditary spherocytosis, right? All of these are simple spherocytosis. So what it is happening in all of these cases, those RBCs, they are breaking at a high pace, right? Because RBCs, they are defective. RBCs are defective, so they will break. Once they will break, that our dear spleen will come into picture. He'll start eating them, right? That is what is called as the macrophage, right? So macrophage, like that Pac-Man, right? That Pac-Man, right? Ooh, right? That way it will start eating. And now comes the interesting part. This splenic macrophage, they'll eat, and thus there would be formation of increased bilirubin. Okay, but we need to add one word, and that is unconjugated. Unconjugated. This unconjugated is what? This unconjugated is because it is the liver. Liver is so decent, right? He'll help a lot in this. But spleen will say my function is to eat them up, and this is the release of increased bilirubin unconjugated, and these unconjugated are high molecular weight. High molecular weight. And these unconjugated bilirubin, they cannot pass through the kidney. This means they will remain into circulation. When they are into circulation, it is this what leads to yellow color, right? That entire yellow hue to the body everywhere, yellow color, that is because of it. Okay, Chalo, from here it will go to liver. Liver is there, right? So liver is there. Liver will break it, right? So it will do bilirubin, but now it is conjugated. Right? It is conjugated. Now this conjugated is fine, right? It can be, it is low molecular weight, and it can be excreted via kidney, right? Everything good. But then some of it sneaks into the gallbladder. This unconjugated one, right? This unconjugated one, it sneaks into. So this unconjugated bilirubin, it goes into the gallbladder, and there it comes in contact with that calcium. And then they make that historical stone, and that stone is gallstone, right? But because it is the bilirubin, so these stones are blackish, right? They are dark colored. So about 6 to 10% of the cases, right, it is like these type of salts. Okay, now I know these topics are a bit heavy, but really worth knowing about some facts. Say, initially I thought that I'll not discuss this part, but say when you try to learn these things separately, na, then it becomes very boring. Right now, as we are dealing with the entire extrahepatic circulation, so it becomes interesting. So just hang on, right? I know it is, we are over 1 hour, but direct and indirect. And really trust me that there is so much of confusion, right? So my job is to make it as simple as possible. What is direct and what is indirect? If the direct hemoglobin, right? I mean the direct, not hemoglobin, bilirubin. If the direct bilirubin is increased, this is the clear indication that liver is unable to pass bilirubin after this conjugation, right? So liver is doing its work, but that bilirubin is not going further, right? Liver is unable to pass, and this is after conjugation. That means liver has done his work, but liver is telling that there is obstruction, so I am unable to send this bilirubin, conjugated bilirubin, further. So in that case, it is the direct bilirubin which will be increasing. What about indirect? Well, in indirect, liver is at fault, right? Liver is at fault. Liver is unable to conjugate. Liver is unable to conjugate. It is the problem of liver. So over here, this is because of some obstruction, and over here it is the hepatic pathology, right? It is the hepatic pathology. Or it could be that there is so much increased production of bilirubin, maybe because of that hemolysis, that is like sickle cell anemia, right? That could be also the thing. Or increased this bilirubin production, that is because of hemolysis. And example, we just write sickle cell, right? Sickle cell anemia. No, though there are many other reasons, right? That hereditary spherocytosis, etc. But just one example is enough. So to give the idea, so that's where when the reports would come, you will see it like this. Okay. The term is cholelithiasis, right? Those stones, cholelithiasis. they could be symptomatic, but at times they could be asymptomatic. And when it is asymptomatic, don't do anything. No need to do anything, right? Because let them remain over there, because they are impacted in such a way that bus they are at that position, not making any of the changes, not giving pain, not expanding, nothing. So no need to worry about it. If it is symptomatic, so in that case we saw that it is the pain after food. Pain after food. Well, in asymptomatic means by chance you are doing ultrasound, you come across porcelain bladder, porcelain gallbladder, right? In that case, it is necessary to remove it, because otherwise it may lead to adenocarcinoma, right? The future complications are there. So I'm just writing that, say, porcelain gallbladder, right? Because of chronic condition, right? Chronic cholecystitis. Cholecystitis. So in this case, on routine ultrasound, you see it. So cholecystectomy, that is you remove cystectomy, you remove gallbladder. Why? Because there is future complication could be adenocarcinoma. That is possible, right? How will you really treat it? Well, there are only two things. One, you go for the surgery and remove it. And if the patient tells, no, 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 I don't want to go for surgery, right? So in that case, you have to give him those hydrophilic bile acids. So they are called as the hydrophilic bile acids. And these bile acids, they will do just the reverse of it. That is, they will decrease cholesterol, that is the biliary cholesterol, and they will increase bile acids, so that whatever the cholesterol is there, it can be soluble, right? And one of the drug is like, it is called as urso deoxy UDCA, colic acid. So that will do the trick, right? Okay. So we talked about chronic cholecystitis. For the acute cholecystitis, that happens when the stone is impacted, right? Stone is impacted. Let's say in Hartmann's pouch, and it is constantly rising, it is constantly increasing in size. Now that will lead to pain in right upper quadrant. Right upper quadrant. And if this pain is going towards right shoulder, right? Right shoulder. Or if it is going towards, say, tip of scapula. So they will be called as the referred pain, right? We talked about it, referred pain. And this particular sign is called as the Boas sign, right? Boas sign. So this is one. The second very interesting thing, though we discussed briefly about it, that it is this right upper quadrant, right? You palpate. I'll change the color, right? You palpate, right upper quadrant, right upper quadrant. But this time you tell the patient that take a deep breathe, right? Deep breathe. And though funny, you are just watching, is the patient doing like, right? Because when the diaphragm, right? When the deep breath is taken, so that diaphragm will hit bichara already bimar gallbladder, right? And it will lead to pain. So patient would say, let the doctor say whatever he wants, I won't breathe. So he will stop his breathing. So breathe is held, right? And this is called as positive Murphy's sign. Positive Murphy's sign. I got a mail in which I was told that what are the important topics. Well, gentlemen, topics are all important, right? But wherever I have marked these stars, right, this means these are the things which are important from the USMLE point of view. If they are important from USMLE, they are important from every competitive exam, right? Okay. In these cases, you will find increased alkaline phosphatase. You will find increased C-reactive protein. You will find increased WBC, right? This means that yes, tissue damage is there. This means there is definite inflammation, right? Okay. Rebound tenderness you were asking, right? Let's write it over here. Rebound tenderness. In fact, so when we are dealing with acute cholecystitis, right, you find that Murphy's sign is positive. But then you say you press and then when you take it and then the pain comes, right? So that is what rebound tenderness, right? Rebound tenderness. So which will be like for peritonitis. That means situation is bad. Now the infection is spread to this peritonitis. Yes, referred pain is always associated with dermatomes, right? It is always associated with dermatomes. So over here, actually speaking, right, when we talk about this Boas sign, it is because of the involvement of that phrenic nerve, right? It is because of the phrenic nerve, the pain is into the right upper quadrant. Means that pain is into the right shoulder. Yes, you are right. That is because of the dermatome. The pain which is actually, right, pain which is, there is a pain, it is actually carried to spine, right, and from that same segment, right, the other nerves are coming out. So it is as if a short circuit. So it feels like that here also there is pain, but actually it is because of those dermatomes. The dermatome is like area which is supplied by the same root value, right? So it is dermatome. That's right. That is the basic principle of referred pain. That's right. Okay. Right. So that is the rebound tenderness. You press and when you take and patient shouts. So this is peritonitis. When this sign develops, it is like, just remember you have got 72 hours. Because this means that because of this cholecystitis, chances are that even the blood supply is trapped, and if it happens that then that gallbladder might go for the necrosis, and it may lead to the peritonitis, right? May lead to that rupture, and that's where that if this sign is developed, it means it is a sort of emergency. Within 72 hours, just handle the case, right? Yeah, that's right. It is like pain is always a good thing because it tells your body that something is not okay, right? Acha. Guarding rigidity was also asked, right? Guarding rigidity. Guarding rigidity means, so when the infection is high, so even when you press it, right, patient would try that no, right, you should not even press it. So he'll tighten his muscles. So the abs, right, they will be so tight, right, that you won't be able to actually palpate the things, right? This is what you see it in intussusception. Because the pain is so high, so the abdominal muscles, they will just guard it in such a way, they will become so strong, so contracted, right, that it becomes completely rigid, so that we can't even feel the things properly. So that is what is called as the guarding rigidity, right? The rigidity of the abdomen, so that they are guarding the underneath area so that we don't palpate, right? See, this is actually the Murphy's sign, right? So if we actually divide, so that's where this right hypochondrium, right hypochondrium, and this one would be the right lumbar, correct? So it is this area what we are palpating. Typically, if it is asked in exam that where will you place your fingers, so this is like tip of ninth costal cartilage. This is the exact location, right? And rest of the procedure, you know, this we are dealing with, say, Murphy's sign, right? So complete Murphy's sign, that at this point you just press, tell the patient that okay, take deep breathe, inspiration, and then if he holds his breath, right, that is the catch in his breath, so then it is what's called as the cholecystitis. Cystitis, right? That's the thing. Okay. Some, in case of cholelithiasis, that is the gallstone. These are the gallstones, and the wall, they are thickened, right? So when we say cholecystectomy, so that means gallbladder is removed, right? Gallbladder is removed. So there can be intrinsic obstruction or there can be extrinsic obstruction. So intrinsic obstruction, that means something is wrong in the gallbladder itself, inside the gallbladder, right? And that is like those stones, gallstones. So in such cases, that gallbladder size is usually normal, right? It is normal, but definitely there would be associated fibrosis. So how will you really see these things? Ultrasound, USG. Because in ultrasound, you'll be able to see the consistency of the gallbladder, right? We'll watch it. When the entire gallbladder is filled with the sludge means all those particulate biliary salts, etc. So its consistency, right? Its appearance, that would be similar to liver. So that is what is called as the hepatization of gallbladder. We'll see an image. I've got that, right? And when we talk about extrinsic obstruction, right? When this is extrinsic obstruction, that means this obstruction which is from outside. Say for example, CA pancreas, CA head pancreas, right? So this pancreas, it has choked this common bile duct. That means the back pressure, that will lead to dilatation of gallbladder, right? Typical dilatation. And when the gallbladder is dilated like this, it is called as the Courvoisier's sign, right? Such names. Courvoisier's sign. Right. Okay. Now in very rare case, very rare, huh? But if it happens, it is emergency. Those gallstones, right? Somehow they reach to duodenum. Now they can reach to duodenum in many ways. Say because of that carcinoma, right? Gallbladder starts expanding, right? It is dilated. It comes in contact with duodenum, and it forms a fistula. It forms a fistula. Through that stone enters into duodenum. From that duodenum, it starts traveling because there is no problem. It goes all the way to the intestines. it reaches to that ileocecal junction. Ileocecal junction. Now it is this ileocecal junction where things are very narrow, right? It would block it. And that would lead to intestinal obstruction. Intestinal obstruction, right? And this is what really, but this is pretty rare, right? Pretty rare. All right, here it is. First thing first, we are using a curved probe, right? We are using a curved probe, correct? So wherever the probe is, and we are going deep. So this is abdominal wall, that makes sense. Okay, this is the liver, all right. This is, say, pericholecystic fat. That is the fat which is surrounding the gallbladder. That's the gallbladder wall. And here are the stones. See the stones. They are seen so clearly. But how do we say that these are the stones? Watch for this part. This. See this part. That's the shadow, right? That is what is called as the acoustic shadow. Acoustic shadowing, what we were discussing in the initial stage, right? That's the torch and then the beam, and if there is anything over here, so then just behind there is darkness. Behind the object there is darkness because rest of them is lighted. So this is what is called as the acoustic shadowing. This acoustic shadowing is classical pattern that this is a solid structure and behind it those patterns, those sound waves, they are not going, right? So they are the stones. And then this one is sludge. Sludge means nothing but all those bile salts, right? Now they are into the particulate, small particulate thing, and they are floating, right? So that is what is called as the sludge. Okay, one more. So this is typical cholelithiasis, classical, because these are the stones, and awesome acoustic shadow, right? See how nicely the acoustic shadow is seen. Shadow is dark, but why it is highlighted or bright? No, it is dark. See, this is a dark thing. Here also, this is definitely dark, right? As compared to surrounding. Where is it shown bright? It is dark. Say here, so it is definitely dark, right? And those are the stones. Because these stones, they are seen bright because the sound which is going over there and it is getting powerfully reflected. So those sensors, they picked up that sound and converted into the image, and yes, it is seen as bright. This is seen, the shadow means it is seen dark because there is no reflection coming from that area, right? The shadow of stone, yeah, it is dark, right? This shadow of stone, what you are watching behind, it is dark. Where is it bright? Where is it, right? It is not at all bright. It is completely dark. See, the black patta, this black, right? That is. Okay. See, this is what is called as the gallbladder hepatization. This is liver. This is gallbladder. They both are looking almost similar, right? That echogenicity, right? It is similar, and that is because of sludge. Yes, water is always our friend in ultrasound, always, right? It is always friend. So this is important, that why the echogenicity of gallbladder is equal to liver. Why is that happened? It is because this gallbladder is now full. It is full of biliary sludge, right? Biliary sludge. And the sludge is actually, it is like kachra, right? It is like kachra, and that is because of those solids which are precipitated from bile. So it has got cholesterol crystals and all those calcium salts and all those mixtures, right? So that is all the particulate solids, all right, which is comprising of all cholesterol salts and those calcium, etc. So that's why its consistency, ecogenicity is as good as liver. So this is what is called as the gallbladder hepatization, right? And this one is actually very fine. This is what is called as the, I deliberately kept the best thing for last. This is endoscopic ultrasound, right? So this is EUS, what is written is endoscopic ultrasound. To see this thing, the probe is inserted via esophagus. So this is esophagus, and that's what you are watching, right? That's the probe, right? So this probe is inserted via esophagus, and then you are watching the rest of the structures. So obviously patient is sedated in such cases, right? Because you are passing that entire probe via esophagus, and then you are reaching, and then you are doing the ultrasound. But obviously you are in direct contact with the structures, so it would be much more comfortable, and you'll be able to see everything into the form of that circular system. uh Snail without shell, yeah. Right, so that's the thing for today. Thank you so much. File has been saved. I'll put it into our folder. All right. Thank you, and we meet tomorrow, same time. Bye bye.